So good afternoon, everybody. I just want to make mention here that I know last week we mentioned we're going to have the ability to help out with the professional development committee. So right now we are looking for 3 to 4 people to join the subcommittee that's being developed. This is to review our grand rounds content. So if you're interested, please contact Dr. Cruz with an email and we can give you some more information on that. Next slide.
Sorry, it's not advancing. There we go.
So today's family medicine grand rounds for February 3rd, your event code is 34047. I will be putting that in the chat box again here later in a little bit, but you can go ahead and register for that through your cell phone, smartphone, or your computer. Please make sure that you do register by midnight in order to receive CME credit if you are wanting. Next slide. I want to thank you in advance for muting your microphone as we begin our presentation, also being attentive and engaged in the session. And then of course at the end, I will be putting in the link for the evaluation if you can fill that out for us. And so this is the South Texas Regional Family Medicine Grand Rounds, along with our educational partner, the South Central AHEC. Our department's mission statement is inventing a healthier future for families and communities in South Texas and beyond through excellence in patient-centered care, research, and education. Next slide. So CME transcripts, if you are needing access to that, you can go to the CME website listed there. If you have any issues, you can feel free to call or email the CME office. The information is listed there. Next slide. And then also those who are wanting AAFP credit, please follow the phone number or the address there for the AAFP organization. Next slide. Dr. Porter has no relevant financial interest with commercial interest to disclose. So today, we have Dr. Ann Porter from the Department of Obstetrics and Gynecology. She is from our school here at UT Health San Antonio. She's going to be discussing with us the surgical management of abnormal uterine bleeding. So I will let her go ahead and take it away.
Hi, thank you so much for this opportunity. I'm really grateful for the chance to come speak. I did graduate from medical school here and was in Dallas at UT Southwestern for residency and then fellowship in minimally invasive gynecologic surgery, and then returned to San Antonio happily in August and joined the faculty here. So since that time, it's been about 6 months since I came and joined the faculty. I've shared a number of patients with members in your department, and I'm so grateful to work with you guys. So I'm happy to have the opportunity to talk about some of what I do in terms of surgical interventions for abnormal uterine bleeding. Okay, so I'm going to review, first of all, how we define and classify abnormal uterine bleeding. We'll talk a little bit about how I work up patients and surgical selection, and then we'll talk about some of the options that I offer patients, including the risks and benefits of each option. So the first thing is to start by defining normal in order to know then what is abnormal. So a normal cycle length is anywhere from 21 to 35 days. And that cycle length can range by up to about 10 days in patients even. But it's a regular, predictable, fairly predictable cycle. Average cycle duration is 5 days of menstrual bleeding, but anything less than 7 days is considered within normal. The average volume over the course of single menses is generally less than 80 milliliters, although as you can imagine, this is hard to quantify. So research studies have done a number of techniques looking at, weighing pads and, using visual charts such as the one I have presented here, where you score the amount of bleeding. And actually, surprisingly, more common is the DIVA cup. Number of patients are using that, and that allows for some quantification. Although I never ask personally for patients to quantify in an objective fashion their blood loss. I generally try to get at it more from a subjective qualitative standpoint of how many pads are you using a day, and are those pads saturated, and trying to get a descriptor. And there's less of a definite cutoff there between normal and abnormal when you're using the more subjective measurements. But it helps me sort of give some quantification to their experience. I also ask a few other questions that help get at how their bleeding is affecting their life. So I ask patients, do you flood your clothes? Patients will tell me, yeah, I had to leave work and change. I keep a change of clothes in my car at all times because I, never know when. And that's obviously significantly impacting their ability to lead a normal life. I ask patients, have you ever had an anemia or a transfusion? And if they say yes, I ask further questions to determine whether or not those are actually related to heavy menstrual bleeding. But if so, that can be a sign that this has been a significant problem for them. And I also ask if their bleeding limits their ability to participate in any number of activities, work, going out. For some patients, the quantity of bleeding is not actually significant enough to cause an anemia, but the bleeding is very distressing to them. Sometimes patients who are having large clots or irregular bleeding, post-coital spotting sometimes can be very emotionally distressing, and then it's interrupting their ability to be intimate with their partner. And so I try to get a sense of how is this interfering with their function. So in 2011, the Federation for Gynecology and Obstetrics, or FIGO, adopted the Palm-Cohen classification system for causes of abnormal uterine bleeding. And on the left, there are structural abnormalities of the uterus, and this includes polyps, adenomyosis, leiomyoma, and malignancy. On the right are non-structural causes: coagulopathy, ovulatory dysfunction, endometrial factors, iatrogenic causes, and those causes that may be identifiable but not otherwise classified. The classification system was developed primarily through expert consensus. I asked other people, what do you think are the important causes of abnormal uterine bleeding? So this is just a system that we've agreed on. I don't always have the information to assign a category, but when I do, I try to indicate that in my notes because it gives me some idea of what treatments we should be considering for this specific patient. So abnormal uterine bleeding has replaced terms like dysfunctional uterine bleeding or menorrhagia. Other useful terms include heavy menstrual bleeding, and that to me is a sign that patient's having cyclic bleeding, so they're ovulatory, but having heavier bleeding, or intermenstrual bleeding, which used to be called metrorrhagia. So polyps are largely benign growths, overgrowths of glandular epithelium. They can come from the endocervix or the endometrium. They're most often detected on ultrasound or hysteroscopy, but can be seen sometimes on clinical exam, particularly cervical polyps, but even large endometrial polyps can be visualized on vaginal exam. Fewer than 5% are malignant when we look at patients in any age group, and they generally cause symptoms of cyclic heavy bleeding or intermenstrual or sometimes post-coital spotting. So adenomyosis is a benign invasion of the endometrial basalis into the myometrium. Clinical triad is classically abnormal uterine bleeding, dysmenorrhea, and an enlarged tender uterus on exam. Classically, this was a pathologic diagnosis that came from hysterectomy, but we've gotten better and better at detecting with ultrasound, and our sensitivity in centers that are looking for adenomyosis is as high as 80%. It can also be identified on MRI, though that's not usually the first test. Obviously, any of us is ordering to work up abnormal bleeding. So the findings on ultrasound include myometrial heterogeneity, increased vascularity of the endometrium, echogenic rests within the myometrium, and myometrial asymmetry, and specifically a predilection for posterior wall hypertrophy. So leiomyomata are colloquially called uterine fibroids. These are benign monoclonal fibromuscular tumors. They are hormonally responsive. They grow throughout the reproductive lifespan, and they're incredibly common. So I have patients who come to me and say, I have fibroids, what do I need to do? And I say, well, you know, by the time we look at women in their late 40s, 70 to 80% are going to have fibroids, more common in families, more common in African-American women, and only a third of these fibroids are actually symptomatic. When they're symptomatic, the complaints are usually either bulk symptoms from uterine enlargement, and that can be constipation, a feeling of bloated, urinary frequency or urgency can sometimes result as well. Abnormal uterine bleeding, certainly, and pelvic pain, which can be cyclic or acyclic. These have their own FIGO classification, and you can see in this picture here, they're classified based on location. And this is useful because their location often gives me an idea of whether or not these might be symptomatic. So the fibroids that are more likely to cause abnormal uterine bleeding are those with a submucosal component, and those are graded from 0 to 3. Less likely are subserosal tumors on the outer side of the uterus, although those can cause some bulk symptoms. And even intramural fibroids can cause abnormal uterine bleeding without a submucosal component, particularly large ones that cause some vasodilation, angiogenesis, and just increased uterine bulk. And they also cause some vasocongestion, which can cause symptoms of abnormal uterine bleeding. They're not thought to transform into leiomyosarcoma. That is a different process, although they can present similarly. I'm often asked by patients if these are going to turn into a cancer, and I generally reassure patients, if I don't think that they're cancerous right now, that they do not transform. So the category malignancy includes both invasive cancer and pre-malignant hyperplasia of the endometrium. The newer term for neoplasia of the endometrium that shows cytologic atypia is endometrial intraepithelial neoplasia, or EIN, although the old term complex atypical hyperplasia is still used. And in fact, this classification also includes simple hyperplasia with nuclear atypia. Simple hyperplasia without atypia is now broken out and not included here as a pre-malignant lesion. Category also includes both sarcomas and carcinomas. Invasive cancer then is further classified based on either WHO or FIGO classification systems. So disorders of hemostasis can certainly be at the root of abnormal uterine bleeding. Inherited disorders often present around the age of menarche, such as von Willebrand's. But we also see acquired coagulopathies. These can certainly be treated surgically if medical management is not an option for these patients, and often patients who have comorbidities, it may not be. So ovulatory dysfunction is one of the most common causes of abnormal uterine bleeding that I see. I spend a lot of time in clinic discussing just normal menstrual physiology with patients. So I explain that there's an estrogen-dependent proliferation of the endometrium that's followed by transformation to secretory endometrium under the influence of progesterone that's produced by the corpus luteum. About at the end of the cycle, progesterone levels fall and you get a nice shedding of that endometrium, a withdrawal bleed, and the whole cycle starts over again. Of course, I don't use the picture above, but I do have pictures in clinic that I go through, and I find that this is new and interesting to a lot of patients, just how their bodies work. Generally, the point of my counseling, though, is that a failure to have a period every month is a failure to ovulate. So the ovary doesn't produce that corpus luteum, doesn't switch over from estrogen to progesterone production, and you don't get that transformation from proliferative to secretory endometrium, and you can just get continued endometrial proliferation. This can result in prolonged unopposed estrogen levels. This increases the risk of hyperplasia and malignancy. Even in the absence of atypia, thickened endometrium can slough off in an unpredictable and sometimes heavy bleeding. So this can be due to hormone dysregulation at the level of the ovary or beyond. Other endocrinopathies can result with similar symptoms as well. And this is associated with hypothyroidism, hyperprolactinemia, polycystic ovarian syndrome, of course, we see very common, but also extremes of weight, so obesity because of peripheral aromatization, and also anorexia, generally through hypothalamic dysfunction. Also extremes of age are a risk factor for ovulatory dysfunction as well. So within 3 to 5 years of onset of menses, you can still see some immature hypothalamic pituitary axis, ovarian axis, that can result in some irregular bleeding, and then also around perimenopause. Okay, so cyclic heavy menstrual bleeding that cannot be classified in any of the previous categories is likely due to what we call disorders of hemostasis at the level of the endometrium. So this can include deficiencies in vasoconstrictors such as endothelin-1 and prostaglandin F2 alpha. Can also be accelerated fibrinolysis due to excessive production of plasminogen activator. Disorders that influences hemostasis, such as chronic endometritis potentially, and definitely there's some evidence that chlamydia trachomatis can influence the ability to maintain hemostasis at the level of the endometrium. But most of this dysfunction is not actually classified or diagnosed in any meaningful way clinically. So iatrogenic, this most commonly refers to breakthrough bleeding as a result of gonadal steroid therapy with either estrogen, progesterone, or some combination of the two. Breakthrough bleeding specifically refers to unscheduled bleeding outside of the setting of hormone withdrawal. So on cyclic cyclic birth control pills, there's a provoked withdrawal bleed. Breakthrough bleeding is a little bit different. That's unscheduled bleeding. This can also be due to increased hepatic metabolization of steroid hormones due to other medications. So commonly anticonvulsants, tobacco use increases hepatic clearance, and antibiotics, so griseofulvin and rifampin can also increase clearance. Tricyclic antidepressants can disrupt the hypothalamic pituitary ovarian axis, and these can cause iatrogenic disruption in ovulation and abnormal uterine bleeding as a result. Okay, so these are etiologies which differ from the endometrial disorders of endometrial hemostasis in that they're diagnosable, identifiable, they just don't fit any other classification. And there's disagreement about where to put chronic endometritis or even exactly how reliable of a role that plays in abnormal uterine bleeding. And so you kind of see it pop up in both categories. You can also see globalized myometrial hypertrophy, cause just an increase in uterine volume and increase in bleeding, and rarely, but occasionally we do see arteriovenous malformations. So before I consider surgical management in patients, I want a basic workup, first of all, ruling out pregnancy. Lower genital tract pregnancy, bleeding in pregnancy is just a whole other can of worms. And then I also assess for some degree of anemia, and if present, I generally send iron studies. And a pelvic ultrasound on almost all of my patients. For virginal patients or patients who can't tolerate a pelvic exam, occasionally this will be abdominal, but generally transvaginal ultrasound is preferred. I do chlamydia screening on all of my patients and cervical cancer screening. Even if I don't think that the bleeding is due to cervical cancer, I want to have cervical cancer screening up to date on any patient that I'm taking to the OR for any reason. So beyond this, my discussion of surgical management with patients hinges largely on weighing risks and benefits. Much of what I do is elective, and so the benefits are really largely quality of life. Certainly there are patients who have severe anemias that are requiring recurrent transfusion and not responding to hormonal therapy. But the vast majority of patients who are coming to my clinic and seeing most of us as gynecologists as outpatient, this is a quality of life intervention for them. So it often comes down to what degree of relief are you looking for? Are you looking for complete or definitive relief, or are you willing to accept improvement in symptoms, but maybe not complete relief? And also, how far out from menopause are we, and how willing are you to accept a risk of needing further treatment down the road? And then I talk to them about the procedural risks. I take into consideration their comorbid conditions, many of which will increase their surgical risks. Surgical history also influences my discussion. Occasionally we see patients who are just have had multiple operations. Previous surgeon has said would not enter this patient if you could avoid it. And so certainly that influences our counseling in terms of risks as well. And then also the expected recovery can be a risk as well. How much time or disruption do they want from their normal routine? So I try to get a sense of the patient's goals. A particular divergent point is whether or not they're satisfied with their fertility, or whether they want the option to have more children. That doesn't always have to be, it's not my decision or role to decide whether or not that's a realistic hope for them. If they would like to retain that possibility, then that's a reasonable goal. I also talk to patients about whether or not they are comfortable losing their uterus or not. There are patients who have completed fertility and may or may not have already chosen some form of permanent sterilization, but don't want to lose their uterus. And that's also reasonable. I talk about, again, how much does their bleeding impact their quality of life? And so we're weighing that against then how much a treatment is going to impact their life in the short term. And then of course I talk about any comorbid gyn conditions. So I screen all surgical patients for urinary dysfunction, lower GI dysfunction, and pelvic pain, because those influence the treatments that I offer or recommend, and also may require some additional surgeries, which I'm not going to talk about here. We'll focus just on surgery for bleeding. So I often think about these options as a continuum, and on one end there are the lower risk procedures, and that's kind of at the top of the screen. These also tend to have a lower reward. In other words, they're less likely to affect complete resolution of symptoms, and they might be shorter term in terms of their intervention. But non-surgical interventions such as uterine artery embolization and MR guided focused ultrasound are options for patients. There are uterine sparing surgical interventions, so hysteroscopy, endometrial ablation, radiofrequency myometrial ablation, and then myomectomy is a uterine sparing, although it's still a pretty significant surgical intervention. And then, of course, on the definitive end, but also on the higher risk end, is hysterectomy. Okay, so uterine artery embolization, it's also known as uterine fibroid embolization, and it's been studied for both fibroids, adenomyosis, and there's maybe some data that suggests that even if you don't have a focal pathology, that uterine artery embolization may provide some reduction in menstrual bleeding. It's performed through interventional radiology, primarily on an outpatient basis, although some patients do get admitted to the hospital for management of postoperative pain. It involves placing a small catheter through the femoral artery, feeding that to the uterine artery, and releasing small polyvinyl alcohol particles. They look kind of like sand into the uterine arteries. These are preferentially going to go to wide diameter vessels that feed uterine fibroids, which is why the largest efficacy in patients is in patients with large uterine fibroids. But it, again, can also cause kind of a diffuse coagulation and ischemia. Of course, the uterus has got collateral blood flow through the uterovarian arteries. So it doesn't actually cause uterine necrosis, but it can cause specific tissue ischemic necrosis. So it's been extensively studied for treatment of uterine fibroids, like I said. There's a clinically significant improvement in uterine bleeding. So this is assessed not with volumetric measurements, but usually through symptom scores. There's an up to 40% reduction in uterine size. Generally see the maximum benefit at about 3 to 6 months post-procedure. And it's got a short recovery, so particularly for patients who don't suffer from post-op pain or post-procedure pain, the recovery is on the order of days to a week, with a faster return back to activities. So there are some limitations to the procedure. It doesn't work very well for patients with pedunculated myomas. They generally have a narrower neck to that blood supply. And so it's just the treatment is not as effective for those fibroids. There's also a concern that if there are pedunculated submucosal myomas that do undergo some degree of necrosis, they might actually prolapse. And the same can happen for subserosal myomas. There was actually a patient when I was in residency who underwent UAE and had necrosis and an amputation of a fibroid, a subserosal fibroid that then parasitized to bowel and caused a bowel injury. Extremely rare, but generally we limit this to patients who have intramural myomas or adenomyomas. And then it's contraindicated in patients who desire future fertility. So there have been patients who have had unintended pregnancies, and there has been an increased rate of placental abnormalities, fetal growth restriction, and preterm delivery. So we tell patients you cannot get pregnant after this procedure. There's what's called post-embolization syndrome that occurs in about 10 to 25% of patients, and this is an inflammatory response to the ischemic necrosis, and it's characterized by fevers, a mild leukocytosis, and pain that can be severe enough to require admission and use of PCA for pain control. There's about a 5% risk of minor complication, and that's vaginal discharge, vaginal bleeding post-procedure. There's about a 20% of risk of reoperation. So I make sure that I'm real clear with patients that I tell them that there is a risk that you could continue to have symptoms and that those symptoms might or might not be severe enough for you to want additional treatment after this. Of those patients who do seek further procedures, about 12 to 13% of them are going to go on to seek hysterectomy. About 4% of them go on to want a myomectomy, and about a little less than 2% of them undergo a repeat embolization. So a separate technique is called MR-guided focused ultrasound, and this is an FDA-approved technique that uses ultrasound energy to heat tissue. And in the case of MR-guided focused ultrasound, the MRI is used to map the uterine pathology, and then the ultrasound transducer is actually part of the MRI table. And then is being applied to the tissue. This is primarily used for uterine fibroids, but it's been studied in adenomyomas and diffuse adenomyosis as well. And so it may have some benefit there. So it is FDA approved for patients who desire future fertility. There have been a couple decent sized series of patients who have gone on to achieve pregnancy. The largest was 54 patients, 64% vaginal delivery rate. There were some placental abnormalities, but they were all attributed to other pre-existing causes, and no specific pattern of complications was identified. So this is generally a procedure that we can offer patients who say that they want to retain the possibility of future fertility. There's about a 30 to 40% reduction in leiomyoma volume. A little bit less when we're looking at this in focal adenomyomas, and it's a little less clear the volumetric reduction in patients with diffuse adenomyosis. So sometimes the pathology affects my specific counseling, but there's about a 50% reduction in symptoms at 12 months for both groups. So overall, the opportunity for some good patient satisfaction. Limitations. In studies, this has been limited to patients who have a uterine size less than 24 weeks. So these are kind of exclusionary criteria. It's less effective for myomas or pathology that's greater than 10 centimeters. And the depth of pathology greater than 12 centimeters increases the risk of treatment failure as well. So you can imagine posterior myomas or even anterior myomas in large patients could be difficult. Prior cesarean delivery is not a contraindication, but can affect treatment efficacy as calcifications or other changes in tissue density can as well. This is pretty well tolerated. There's a low risk of complication. Complications include things like thermal injury to surrounding organs. It's extremely rare, less than 1%. And then other complications reported are things like a reaction to the ultrasound gel. So if we're getting down to that level, you can tell that the complication rate is actually pretty low for this procedure. But there's a 30% risk of reoperation, so higher when you compare it to uterine artery embolization. And this is a 12-month 30% reoperation rate. Like uterine artery embolization, this risk of reoperation increases over time. And so if we look 5 years out, about 60% of patients who have MR-guided focused ultrasound have undergone reoperation. But compared to UAE, patients who undergo this procedure have fewer opioids, less post-procedure pain, and a higher rate of post-procedure intervention. We don't offer this here at this institution, but there is a facility in San Antonio that does. And there's also a registry online that can help patients identify a facility that does focused ultrasound. I counsel patients that this is an option for them, and I offer them referral to a center if they desire. I haven't had any patients take me up on it yet here, but I think it's reasonable to offer patients all options, even if I can't myself provide that option. Okay, so hysteroscopy is now a surgical procedure. It does not require any cuts on the abdomen. So the advantage is it's done entirely transcervical through the vagina, and it can be used to treat type 0 to 2 myomas generally. So type 0 myomas are the ones that are entirely in the uterine cavity. So greater than 90% of the volume of the fibroid is within the uterine cavity. The type 1 myomas have 50 to 90% of their bulk within the uterine cavity, and type 2 myomas have a significant submucosal component, but are less than 50% in the cavity. Type 0 to 1 myomas, particularly small ones, can be done by just about anybody, any gynecologist, but the type 2 or larger myomas get to be a trickier procedure and are best referred to somebody who has expertise in hysteroscopy. So there was a general rule of thumb to limit this procedure to patients whose myomas were less than 3 centimeters. I did several cases in fellowship that were 5 centimeters, some of which required staged procedures. So in larger myomas, I tell patients we might not be able to get all of it in this procedure and need another procedure in the future. The limiting factor is the fluid deficit. So the fluid that we used for uterine distension to perform this procedure gets absorbed over the course of the procedure, and we set safe limits for that absorption and terminate procedures once that limit is reached, regardless of whether the goals of the procedure have been achieved or not. I generally am able to counsel patients, I think we can get this, this procedure, or I think there's a good chance that you will need additional procedures. Myomectomies are performed in the operating room. Polypectomies sometimes can be performed with hysteroscopy in the office. And particularly smaller polyps for patients who tolerate pelvic exam very well can be performed. And then hysteroscopy also has the benefit of providing us with targeted biopsy. So in patients who I'm concerned about hyperplasia or malignancy, targeted biopsy is actually more sensitive for detecting malignancy than an endometrial pipelle or endometrial biopsy in clinic. And then a therapeutic DNC for patients, particularly those with chronic anovulation, who have just thickening of the endometrium. They benefit from a therapeutic DNC prior to starting medications, just because that tissue is going to cause heavy bleeding until they get to be thinned out. So it's got benefits of being a quick recovery, no incision, and generally considered safe for future pregnancy. In fact, this is one of the types of myomectomy that generally does not require us to counsel towards cesarean delivery in the future. The caveat to this is some type 2 myomas, if there's, a weakening of the myometrium, then in those cases we might discuss the possibility of future cesarean with the patient. There's about a 2 to 3% risk of complication. Those complications generally arise from fluid overload. The risk of perforation or poking a hole in the uterus with an instrument is about 3%. The risk of reoperation is about 50 to 20% for patients. So generally can be very effective, particularly when it's targeted to the right pathology. Okay, endometrial ablation. This is a surgical destruction of the uterine lining, and this can be done a number of different ways. There are lots of techniques out there that use either radiofrequency energy, cold, heat, hot water, to destruct the uterine lining down to the level of the basalis, ideally to prevent regeneration. Many of these techniques for ablation can be done in the office, although it's still an uncomfortable procedure for patients when done in the office. So it's often done in conjunction with an anxiolytic, but can be done in the office, or more commonly are done in the OR. This is a procedure that I generally advise patients is best for ovulatory patients and premenstrual patients. So that's because one of the risks of this procedure is an scarring of the uterus that prevents an ability to diagnose malignancy or hyperplasia in the future. So patients who I think are at increased risk for that, I generally advise them that that risk of being able to diagnose or failure to diagnose something in the future limits this as an option for them. So the endometrial ablation that we offer at University Hospital is called the Minerva ablation. So you can see here there's a little device that gets inserted through the vagina. There's a little cap that sits protecting the cervix here, and then there's an array that's released and is fit to the uterus. And then that array actually heats up and uses thermal energy to destruct the endometrium. And then the array is collapsed and withdrawn. The whole procedure takes less than 2 minutes to actually heat the endometrium. The deployment doesn't really add much significant time. There are some size limitations for this procedure, but in patients who have a uterus that's too large for a Minerva ablation, they can sometimes undergo a roller ball ablation, where we actually manually destruct the endometrium using electrocautery in the operating room. So there's about a 50% amenorrhea rate at 2 to 5 years. This is time limited. So particularly when we look past 5 years out, the rate of amenorrhea starts to drop. That doesn't mean that patients in their late 20s or 30s can't have this as an option, but I generally counsel them that the chance that they might have a recurrence of their uterine bleeding is high. And if we look at patients, again, up to 5 years out, about 80 to 90% of them are satisfied. This is not a procedure for patients who desire future fertility. There is a 20 to 25% risk of rate of reoperation. Now, when I tell patients that, I say that means that 75 to 80% of patients were happy with this procedure, even if it didn't achieve total amenorrhea. But generally, patients who fail this procedure go on to hysterectomy. There's about a 6 to 8% risk of what's called post-ablation tubal sterilization syndrome. And this is highest in patients who have had a tubal occlusion. And so there is actually tube there that then gets occluded on the distal end. This causes scarring, which occludes the uterus on the more proximal end. And if there's any remaining endometrial tissue that's functional, that continues to respond to hormones, that bleeding has nowhere to go and can cause a cyclic pain syndrome called PATS for short, that is treated with hysterectomy generally. And we talked already about the risk of failure to diagnose uterine malignancy. So myometrial ablation, I think, is a really great option for patients. I trained to do this in fellowship. It involves radiofrequency ablation that heats the tissue and induces a coagulative necrosis. This can be done, there's a newer technology called Sonata that's done through the cervix. And then there's a transabdominal approach called Accessa, and that's actually a laparoscopic surgery. There's a picture of it here. So this is an intraabdominal reconstruction, and you can see uterine pathology there with fibroid that's being targeted. There's an intraoperative ultrasound probe. And that's actually more sensitive for detecting fibroids than our transvaginal ultrasound, and actually even more sensitive than MRI in some cases. And you can see when you're in the operating room, you're looking at the ultrasound output, and you can see the array enter the fibroid. It heats the fibroid up for a certain period of time. So it heats to 95 degrees, and then it holds that heat based on the size of the deployment. And you can do multiple treatments for fibroids, or it's more recently being studied in adenomyomas and adenomyosis. And it induces a coagulative necrosis. So it's a different effect than uterine artery embolization, although similar. So it's got a significant reduction in menstrual blood loss, 30 to 40%. So not amenorrhea, but for some patients it's enough, and about a 45% reduction in fibroid size. So this is a great option for patients who have abnormal bleeding or bulk symptoms, but want to retain their uterus. And it's got a 94% patient satisfaction rate. So very high. The Accessa has actually studied patients who desire future fertility. They've had positive pregnancy outcomes, very few pregnancy complications, but it's not yet specifically approved for patients who have fertility. But we advise patients that generally this is an option that you can consider if you desire future fertility. It involves the risks of laparoscopy. This is specifically for Accessa because it is a laparoscopic procedure, and there's about a 9 to 11% risk of reoperation in studies that have looked specifically at Accessa. This is not a technology that we have at University Hospital yet, although I'm trying to bring it here because I think it's a great option for patients, and I've seen a lot of patients really have significant benefit in their symptoms, feel better postoperatively, and the recovery is very quick, closer to a diagnostic laparoscopy. So again, a week to 2 weeks. So myomectomy refers to removing just the fibroid, leaving the uterus behind. And this is a good option for focal disease. Primarily, we think of this as a treatment for fibroids, although adenomyomas can be excised, but certainly presumed benign focal masses. And this can be performed laparoscopically or abdominally. We talked already about hysteroscopic myomectomy. So when we do this through a laparotomy incision, sometimes that's a phalansteal, sometimes that's a vertical midline incision. Laparoscopically can be with or without robotic assistance. Laparoscopic surgery certainly has the benefit of faster recovery, shorter hospital stay, but tissue extraction can be an issue. So it is a fertility sparing procedure, and it has a significant reduction in uterine bulk and bleeding. The group is very heterogeneous depending on the fibroid size, number, location, so expected benefits vary widely from patient to patient. It's got risks of laparotomy or laparoscopy, but specific to myomectomy include a risk of increased blood loss, potential for hemorrhage, coagulopathy, increased need for transfusion, There are intraoperative techniques to reduce blood loss, things like giving tranexamic acid at the start of the cases, injecting vasopressin. You can see here a picture of a uterine tourniquet that's placed around the lower uterine segment during myomectomy to reduce blood loss. And then also prostaglandins can be used as well. Patients are generally admitted to the hospital after open myomectomy and even occasionally after laparoscopic or robotic. There's increased risk of post-procedure pain, and you can have post-op fevers. And that's generally from bleeding into the surgical bed. Of course, fibroids can recur, and any remaining fibroids not excised will continue to grow. I tell patients there's about a 5% risk of conversion to hysterectomy due to uncontrollable bleeding, and recommend pre-labor cesarean section in anybody who's had a significant myometrial resection, which includes most patients with a major myomectomy. Small risk of occult malignancy. I get an MRI on almost all my patients before myomectomy for mapping, and that generally can help me have some reassurance about the nature of the fibroid. So hysterectomy is, of course, definitive surgical management. It's the one thing that I can tell patients will stop their uterine bleeding. The majority of these procedures are now minimally invasive, and there's certainly a big trend towards same-day discharge. The patients, of course, have to have completed childbearing and be okay with removal of the uterus. So a question I get really often from patients, they bring it up before I usually have the opportunity to, is, are you going to take out my ovaries? As a specialty, we've gotten much more conservative about oophorectomy. There's good data from large studies, including Women's Health Initiative, that there's an all-cause mortality benefit to ovarian conservation, and that benefit extends up to about age 65. So even postmenopausal patients less than 65 generally have a mortality benefit from leaving the ovaries in. And that applies to average risk women. So no known familial ovarian cancer or hereditary malignancy syndromes, and also patients who have otherwise normal appearing ovaries. That mortality benefit is likely from an increase in the risk of fracture with oophorectomy, increase in the risk of cardiovascular disease, and actually data suggests that there's an increase in the risk of dementia as well. So this is weighed against the 1 in 70 risk of ovarian cancer. So not a common cancer, but of course a very bad cancer to get. I generally tell patients the data on either side. I recommend ovarian conservation, but in patients with a family history, even if they've been referred to genetic counseling and don't have a hereditary syndrome present, if they strongly desire oophorectomy, then we discuss that, and you know, it may be a possibility. The topic of supracervical versus total hysterectomy doesn't come up as often, but some patients do feel strongly about keeping their cervix. There's a belief that the cervix can play a role in enjoyment of intercourse. This hasn't been borne out in comparative studies, but some patients have said that this is their experience. There's also a concern for vaginal vault prolapse when we disrupt the uterosacral ligaments. We do try to recreate some of this support, although there's no one technique for recreation of the support that's proven beneficial. I think the main argument in favor of a supracervical hysterectomy is the recovery time, which ranges from about 2 to 3 weeks for a supracervical hysterectomy compared to 4 to 6 weeks for a total hysterectomy. However, I'm generally performing hysterectomies for bleeding or pain or both, and there's at least a 5% risk of recurrent symptoms with retention of the cervix, and trachelectomy, the surgery to remove just the cervix after hysterectomy, is much more difficult, much more complicated than a total hysterectomy. So I generally advise patients with bleeding or pain in favor of a total hysterectomy. I do recommend opportunistic self-injectomy for all patients if feasible. There's a modest reduction in the risk of ovarian cancer. This is up to about 40% risk reduction in risk, but of course, again, ovarian cancer is a rare cancer, so the actual benefit on a population level is modest, but I think becoming universally agreed upon. So the route varies based on the size and shape of the patient, the uterus, accessibility to the uterus, extrauterine disease, need for other procedures, and certainly varies based on surgeon training and experience. Minimally invasive hysterectomy, which includes laparoscopic hysterectomy on the right, robotic hysterectomy on the left, and vaginal hysterectomy, which I don't have pictured here, is preferred due to the decreased risk of intraoperative and post-op complications, shorter recovery time, shorter hospital stay, and decreased opioid use. So one of the things that I'm really excited about is vaginal laparoscopy, which is increasing in its use. This allows patients all the benefits of a vaginal procedure, but allows us to do vaginal surgery in patients who have pelvic pain and need a visual inspection of the peritoneal cavity, or who have large pathology. Would be very difficult to reach their upper pedicles through just a vaginal incision without the aid of laparoscopy. This is something I did in fellowship, and I'm looking forward to doing here. It's got the benefits of decreased Trendelenburg, so it's a great option for very large patients who don't tolerate Trendelenburg and don't need the same degree of pneumoperitoneum that you need for traditional laparoscopy. And so it's a really great option for some patients. So in the past several decades, there have been major changes to the way that gynecologic surgery is performed. In this graph, you can see that there's been a decrease in the percentage of benign hysterectomies performed through the open approach, which is the blue line, from nearly 44% in 2008 to less than 25% in 2014. Vaginal hysterectomy has declined, but conventional laparoscopic approach, which is in green, and particularly robotic hysterectomy in purple, have become much more common. So the vast majority of hysterectomies now are performed through a minimally invasive approach, and that's true at University Hospital as well. And over the same period of time, there's been an increasing percentage of cases performed as an outpatient surgery. So about 13% in 2008 to over 50% in 2014. So, you know, I think there are pretty clear benefits in terms of treatment of the patient's bleeding. We really don't understand the long-term risks. So there have been studies looking at how does body image change? How does sexual health change for women after hysterectomy? And it's highly, highly variable. So for patients who have severe abnormal bleeding, who now can have intercourse with their partner because they're not bleeding for 28 days out of every month, quality of life and sexual health are improved. For patients who maybe have milder symptoms, particularly if they have a larger incision or a complication during surgery, then that quality of life afterwards may be impacted by them. I tell patients there's about a 4% composite risk of major complications. This is anything from intraoperative complications like DVT, organ injury, hemorrhage, need for transfusion, and post-op complications, surgical site infection, pneumonia, post-op pain, chronic pain, and the recovery is, we've talked about, it's about 4 to 6 weeks. There's definitely the potential for incompletely addressed ancillary symptoms. So by this, I mean patients who have pain and bleeding. I say the hysterectomy will stop your bleeding. If your bleeding, I think, is due to adenomyosis or fibroids or the uterus itself, then this will likely help, but I cannot guarantee you that you will not have any pain, particularly if there's pelvic floor dysfunction, endometriosis that isn't addressed during surgery, or GI or bladder dysfunction that aren't addressed. Excuse me. There's pretty good data now saying that hysterectomy, even without oophorectomy, does decrease the age of menopause by about 3 to 5 years. There's a decreased ovarian reserve, an increased potential in mood disorders, cardiovascular morbidity, and possibly increased risk of dementia long-term as well. The main point I want to drive home with most of my patients is that they often have been told by somebody else that hysterectomy is their only option, and they may or may not want it. And so I try to reinforce with patients that Unless there's something very severe or emergent, almost all of my patients have options, don't have to do anything they don't want to, and really have the power to balance their risks and benefits as they choose. I have a couple cases, but we're kind of at the end of the talk, so I thought I'd leave an opportunity for questions.
If anyone has any questions, you're more than welcome to either unmute yourself or to put something in the chat box if you'd like. Okay.
I guess I should take this as a sign that I answered all questions that could potentially be asked about this topic. Of course, I'm always available and happy to talk if you have questions. At any time.
Double checking the chat box. I don't see anything, so I can go ahead and we'll conclude. Thank you so much, Dr. Porter, for speaking with us today. A reminder to everyone to complete the evaluation so we can give her some feedback. I put there in the chat box, and if you need anything, as she mentioned, please reach out to her. Thank you so much, everybody.
Thank you for this opportunity.
Sure.
Thank you. This is a very nice overview. Appreciate it.